When nucleotide excision repair fails, the cellular machinery loses the ability to excise bulky DNA lesions caused by ultraviolet light. This breakdown in structural maintenance results in xeroderma pigmentosum. Mismatch repair failures prevent the cell from fixing isolated spelling mistakes that occur during DNA synthesis. As these uncorrected errors accumulate in the genome, the patient develops Lynch syndrome. These conditions represent failures in static repair mechanisms. Genetic conditions also arise from active replication errors, specifically those involving trinucleotide repeats. The core kinetic mechanism is DNA polymerase slippage. During gametogenesis, the polymerase enzyme loses its grip on the DNA template when encountering long stretches of repeating 3 nucleotide sequences. As the enzyme stumbles, the newly synthesized DNA strand detaches and forms a localized loop. Upon the next replication, this physical loop is cemented into the sequence, causing a net addition of repeats. The specific mechanics of meiosis dictate the severity of these repeats. Parent of origin dictates whether the biochemical environment of spermatogenesis or oogenesis makes the polymerase more likely to slip. This expanding sequence manifests as anticipation. As successive generations inherit longer repeat tracks, the disease symptoms appear at an earlier age and with increased severity. Inherited diseases of this class possess a kinetic momentum that alters clinical onset across a family line. Huntington disease illustrates this momentum through the expansion of CAG repeats. These CAG repeats expand within the coding region of the HTT gene, located on chromosome 4. For this gene, the continuous cell division in spermatogenesis creates the highest rate of polymerase slippage. Paternal transmission drives the greatest expansion of the CAG tract. A child inheriting a highly expanded allele from their father can present with severe psychiatric collapse and chorea in adolescence, bypassing the typical adult onset window. Fragile X syndrome operates through a different trinucleotide expansion, involving CGG repeats. As detailed in the etiology section, CGG repeat expansion occurs in the FMR1 gene, driven almost exclusively during maternal transmission. When maternal expansion exceeds 200 repeats, the gene undergoes hypermethylation and silencing, leading to the moderate intellectual disability and autism listed here. The transmitting parent's unique gametogenesis dictates the mathematical severity and clinical presentation of the resulting neurodegeneration. Inherited momentum extends from the genetic code to the physical machines that code builds, the enzymes. To see how these defects force a diagnostic fork, consider 2 infants with organomegaly and hypotonia. Both infants suffer from a high-level metabolic block in glycogen utilization. The first infant has type 1 glycogen storage disease, or von Gierke disease. This technical breakdown locates the defect for von Gierke in the cytosol, specifically a deficiency of glucose-6-phosphatase. Glucose-6-phosphatase is the final cytosolic release valve for gluconeogenesis. Severing this node causes the fasting hypoglycemia and hepatomegaly highlighted in the clinical findings. The backed-up substrate shunts into secondary pathways, resulting in the hallmark lactic acidosis and hyperuricemia. The second infant has type 2 glycogen storage disease, Pompe disease. The etiology involves a deficiency of lysosomal acid alpha-1,4 glucosidase. Because the defect is restricted to the lysosome, cytosolic glycogenolysis remains intact. This prevents hypoglycemia, while the patient develops the rapid progressive cardiomyopathy noted here. Pompe destroys tissue architecture by physically engorging the lysosomes until they crush the sarcomeres. Clinicians who rely merely on normal fasting glucose to rule out all storage diseases will miss this fatal lysosomal defect. Nitrogen disposal requires the urea cycle to cross the mitochondrial membrane into the cytosol. Hyperammonemia triggers a systemic crisis by depleting alpha-ketoglutarate. Without alpha-ketoglutarate, the TCA cycle halts. This diagram shows the resulting biochemical cascade. The body attempts to clear the ammonia through the rapid synthesis of glutamine. Excess glutamine drives osmotic swelling within the astrocytes of the brain. In a neonatal scenario, a 3-day-old infant presents with lethargy and respiratory alkalosis. Serum ammonia is critically high, but blood sugar is normal. An isolated spike in ammonia without hypoglycemia requires an immediate investigation of a urea cycle collapse. Ornithine transcarbamylase, or OTC, deficiency is the prime suspect for neonatal hyperammonemia. Carbamylyl phosphate synthetase 1, or CPS1, deficiency is the autosomal recessive suspect. CPS1 is the rate-limiting step of the entire cycle. If CPS1 fails, carbamylyl phosphate is absent. An OTC failure downstream causes carbamylyl phosphate to accumulate and then overflow into a secondary offshoot, the pyrimidine synthesis pathway. The carbamylyl phosphate leaks into the cytosol and shunts into pyrimidine synthesis. This shunt produces a significant spike in urinary orotic acid, positively identifying OTC deficiency. Flat orotic acid levels rule out OTC and verify CPS1 deficiency. Substrates shunts into alternative pathways when an enzyme fails. Isolating the exact shunt product is the only way to break identical clinical phenotypes. Misinterpreting biochemical shunts in critical care leads to fatal interventions. Treating acute hyperammonemia with blind protein loading provides a broken urea cycle with the fuel to accelerate cerebral edema. Relying on normal fasting glucose to dismiss the presence of deadly storage diseases will miss the advancing pathology of Pompe. In organic aciduria, administering carbohydrate fluids without carnitine supplementation prevents the clearance of toxic metabolites. Consider an infant with metabolic acidosis, fluctuating tone, and an atypical urine odor. The first diagnostic step is the sequencing of plasma amino acids. The second critical diagnostic step requires accurately quantifying urinary organic acids via chromatography to identify specific metabolic blocks. These constants allow clinicians to map cofactor replacement lines to bypass broken nodes. Clinical genetics is the calculated application of biochemical first principles to trace systemic collapse back to a single broken cellular node.